Good afternoon, everybody, and welcome to today's Grand Rounds. Before we get started, I again wanted to express appreciation to Avela Bank, who has been a generous supporter of the CME program here at Mary Greeley and has made programs like today's possible. Today, actually, we have a triumvirate of presenters, and we'll get them introduced and get started.
Hello, my name is Matt Peterson. I'm the director of Mary Greeley's Rehab and Wellness Department. I'm just wanted to give you a very brief overview of the Virtualis and why we brought it to Mary Greeley, and then introduce my awesome staff who will demonstrate it very well for you. So perhaps you saw the feature story in the Health Connect most recent Health Connect magazine featuring the Virtualis. We pursued the Virtualis because prior to that we had Neurocom Balance Master. It's a balance platform, and it became outdated. So as we investigated replacement products for that, everything was going towards virtual reality, and we were able to make a significant investment in this piece of equipment. It not only can perform and do what our Balance Master did, but also really expanded the number of types of treatments, patients we can treat with it. So today you're going to hear from a physical therapist, Lisa Haggas. She is our neuro expert, and she sees a lot of vestibular patients and Parkinson's as well. Kristine Sankey is a speech therapist. She sees some inpatients and outpatients in our outpatient clinic as well. And Linda Power is our OT. She is our certified hand therapist in Story City and Medical Arts. So with that being said, I'll turn it over to Lisa. And while she's coming up here, there's two pieces of the Virtualis. You're going to see the virtual reality environment today with the goggles. There's, as I mentioned, the platform. It's not mobile, so it's over in the clinic. So but there will be a brief demonstration of that as well on video. So thank you.
Hi, I'm Lisa Haggas. Thanks for coming today. Heavily towards doing a lot of demonstrations. So I do have a presentation to give the background of virtual reality, what it is, some of the research behind that, and an introduction to how we can start using that to work with our therapy patients. We have all three of us here today representing physical therapy, occupational therapy, and speech therapy, so that you can get a sense of what each of those therapists might do with this. So hopefully we won't take too long on the slides because the demonstration is the fun part. So what is virtual reality? It's digital technology. A lot of people are most familiar with this in the world of gaming, but it's something that uses visual, auditory, touch. Some of them even have more of a sense stimulus with them to create an artificial environment that encourages people to manipulate objects and perform activities within that virtual environment. There are three types of virtual reality. A lot of people are probably most familiar with the non-immersive, but there's also semi-immersive and immersive. So the non-immersive, the biggest difference is your field of view is not completely the virtual environment. So think of something that you would be using a TV screen, keyboard. So the biggest example, or most familiar example, is something where with the Nintendo Wii. So maybe that has a little bit of a balance platform. You've got the screen, you've got the controllers. It's a real-time environment you're working in, but you can still see your surrounding, living room, TV room while you're working on it. And there's some other examples there as well. Xbox, a lot of people are familiar with that. And then they have something called a Gate Better out there that's a VR enhanced treadmill. Semi-immersive would be a partially virtual environment. That might include something like digital glasses and gloves, which produce the sensation of manipulating items in real time. Maybe it's panoramic TV, so more of your visual field is filled by that input. Gave some other examples of those systems below. I've never used any of those systems, but those are some of the examples of it. Immersive is where your real world is completely displaced by the virtual environment. So that's the most common example people are probably familiar with would be the Oculus. That became really popular, one of those big holiday gifts, so that your VR goggles where you put it on and you can see nothing but the world that you're in through the goggles. And Virtualis is included in those versions of immersive virtual reality. VR technology really capitalizes on neuroplasticity. So you're trying to, the brain's ability to adapt structurally and functionally to change, whether that be learning something new or recovery from injury. We use this to do very task-specific training to help recover whatever specific task you're having a deficit in. Use of VR, because it's a fun environment, it induces repetition, people are more motivated to use it. It's enjoyable. It doesn't feel like therapy when you're playing a game, but at the same time, you have a trained clinician there watching what you're doing and making sure, okay, that's what you're doing? All right, now I'm going to adjust it this way to get what they need from the therapy with you. There's a growing body of research out there that supports the use of virtual reality in therapy. Some of that is in psychological therapy. They have found benefits in relief of anxiety and depression. I'm not going to go into any of that research today. That's beyond the scope of what we're here to do today, but know that that is out there. Some of the areas that VR has shown improvement in include balance, upper and lower limb function, motor control, functional ability, cognitive ability, proprioception. There's been some positive studies that have shown some improvement in pain control and joint mobility. So we can take those areas of research and we can say who can benefit from this type of therapy. Research has looked at various populations, and the ones that they've found some of the most positive benefits for are stroke, traumatic brain injury, Parkinson's, MS, Guillain-Barré. They've done a lot of work with children with cerebral palsy, patients with cognitive decline. They've done some studies with patients that are on hemodialysis, trying to improve their activity level, frozen shoulders, shoulder impingement, arthritis, chronic neck pain, low back pain, and with visual perceptual deficits. The research is constantly evolving. So the technology, 10 years ago, who would even think they would have any kind of Oculus immersive VR in their home that you could just go to the store when it's on sale, of course, and buy and bring home and use. It was not readily available, and more this is becoming more and more readily available. The populations that are most frequently studied include stroke, usually chronic stroke, Parkinson's, and cerebral palsy. But we're starting to see studies of other populations with various multiple skeletal conditions. Burns, there's been a lot of work on pain control with burns, spinal cord injury, hemodialysis again, cognitive decline, chronic regional pain syndrome, and also in healthy elderly populations, looking at this as a wellness tool for them as well. There's a lot of variability in the research for several reasons. Some of those reasons are the sample size. A lot of the research coming out, they simply don't have the sample sizes that you'd like to see for research. Technology is highly variable. Are they using semi-immersive? Are they using immersive? Are they using the Wii Fit, which falls under the non-immersive? And there's great variation in the protocols they're using. I've seen in the reading I did to prepare for this anywhere from 5 days to a 12-week study. Generally speaking, when I read through those, as you might expect, 5 days gave less positive impact than a 12-week study. So when you look at the short studies, they didn't see a whole lot of difference with it. When you looked at the longer studies, that's when they started to see more of the benefits. They also, all the studies compare things differently. So sometimes they're comparing virtual reality with no treatment at all. Sometimes it's virtual reality with what we would consider conventional therapy, or it's virtual reality with conventional therapy versus conventional therapy alone. They've also started adding other tech in with that. So it's VR plus robotic assisted versus conventional therapy. And the list goes on of the different combinations they're using. So it's really hard to get a good apples to apples comparison. So what I've had to do is just dig and say, well, this is who I'm working with. Is this going to work? And what's out there? And then based on that, try to adapt it to other people that might have those conditions or similar deficits, even though the research may not be there just yet. So if you're looking at all of those different variations of research, you're going to see a lot of different results. The one thing that they consistently reported in everything that I could find, that Kristine could find, that Linda could find, was that there were no negative effects. So people didn't have, worsening of their condition because of the use of VR, but sometimes you had a null effect. Sometimes it really didn't seem to make any difference. Sometimes the VR was better than conventional therapy. Sometimes the VR was not better than conventional therapy. But the most common report was VR enhances conventional therapy. So the way we're looking at virtual reality right now is we're using it as an adjunct therapy, meaning it's another tool in our toolbox that we can use. Okay, so if you think of, maybe we used ultrasound, maybe we used electrical stimulation, maybe we used mirror box therapy, maybe these other types of therapy that can help people. It's not just strictly we're going to do VR and that gets you better. We're going to combine that with the other conventional therapy techniques we use. Just one moment. There's a lot of choice in virtual reality systems out there. A lot of the commercial products that you would use for gaming are very stimulating. They're very overwhelming to a population that may have cognitive deficits, that may have physical deficits. And with those, you get what you get. You get the game, and it's really hard to peel back any of the complexity of the game. You just have to go with it. So in response to that limitation, there's been more emergence of VR systems that are specifically developed for rehabilitation with the input from clinicians. For example, Virtualis, they set us up with the system and have invited us to give feedback. What do you like? What do you don't like? What do you want to see us developing? And we can continue to dialogue with them so that their developers can continue to develop programming that will work for rehabilitation populations. So one of the greatest advantages we have with those VR systems like Virtualis is that it allows the clinician to adjust the activity in real time to meet the patient where they're at. So some of the programming you'll see today will look very basic, especially if you compare it to a virtual reality video game, and that is intentional. We can't have an environment that's so overwhelming they can't participate in it at all. So this gives us a lot of control in real time to see how the patient is responding and then adjust the parameters to make it more or less challenging and then advance based on where they need to progress and what those goals are. Matt mentioned that we did our update from the Balance Master. I'll give you a picture of what the Balance Master looked like. Some of you might have been down in the therapy department and seen our box. And he also mentioned that we couldn't bring over the platform. That is not portable. The pieces that we brought over today are portable. But I did include a video of what that looks like. So this is a very, very nice participant. This is Stan Peterson. You might have seen him in the Health Connect. So this is the balance platform. You can see it raises up to get to the point where then it can shift and it can move. In this particular piece, he's doing one of our more commonly used balance tests, the sensory organization tests. You can see it has I'll just play through it one more time. So you can see it. You've got the bar around the outside that he can hold on to. He still is in the VR with it. There's a computer off to the side, which is the same computer we have here, where I'm adjusting and setting things up for him. I'm also giving him reassurance. One of the things we do with this type of therapy or with this type of activity during therapy is giving a good description and reassurance. Once you're in the headset, you really don't see the rest of your environment. You don't know where people are. The rest of the world just disappears. And so it's important that we explain that to the patients, which we do, and tell them what they're going to anticipate. Frequently, we keep a hand on the whole time so they know, hey, the therapist is still there, even the world is gone. Some people jump into it right away, and it's like, okay, I got a hand on you, and then I need to duck because they're really excited about what they're doing, and you can get hit as they get excited doing this. But rest assured, we'd be explaining it. And at any point, the programming can stop. So if they get into it and they're not enjoying it, or they're like, I don't like this, we move on to something else. It's okay. That's okay. There we go. Some of the assessments that we have available on our system are the balance tests that we did with the Balance Master, including the sensory organization test, the limits of stability, which is looking at weight shifting and how far people can shift their weight, the adaptation test, unilateral stance. We also have other assessments available for cervical range of motion, the cervicocephalic relocation test that can be an indicator of impaired proprioception of the cervical spine, subjective visual vertical, dynamic subjective visual vertical, and there's upper limb range of motion testing. There's attention and visual scanning testing, which you'll see some of this demonstrated today through the Stroop test and the Bell's test. There's some memorization testing in there. And then the company continues to develop more testing, and on their list that they've most currently given us is the instrumented BESS, rhythmic weight shift, and the weight-bearing squat. There are some yes, sir?
Upper limb testing. What does it do for that?
So in that particular test, instead of having the old school, which we do anyway, the range of motion with the goniometer, when you measure, you have sensors on their hands and they just move through the various range of motions, and it measures it for you. As a clinician, I'll tell you, if I'm not going to be doing any additional training on that, I wouldn't necessarily say, oh, we have to stop everything and do the VR to measure your range of motion. Otherwise, it's just like, well, just get out the goniometer and do it. But those are nice numbers to have. If you're going to be in there anyway working on a shoulder, just measure it real quick. It doesn't take very long, and it saves all the information for you. Some of the precautions are this one, seizure disorder. Now, I did see a couple of pieces of research where they're actually using virtual reality with patients who experience seizures as a type of therapy. I did not take a deep dive into that. So it was listed for the Virtualis system as a precaution. So we're going to treat it as a precaution, knowing that there's some other types of VR that might be appropriate for seizure disorder. They recommended caution if they have an implanted medical device, i.e. a pacemaker. When we asked about that one, she couldn't give us a real great reason as to why, so it's listed as a precaution, not a contraindication, okay? Meaning we can still do it, doesn't mean you can't do it because you have a pacemaker. I know Kristine has already experienced a patient with claustrophobia, so sometimes it's not the first choice for them. Pregnancy, we've also experienced somebody with a craniotomy or any condition where the head should not be squeezed, and somebody with severe motion sensitivity. Now, you can use some of the training modules on this to work on motion sensitivity, but if that's not what your patient came to you for, might be best to not put them through that. So if they're not there to work on their motion sensitivity, maybe we find something else to do with them instead of VR, because if it is severe, they will not be comfortable in this. So I'm going to go through some of the examples of programming for physical therapy that are going to be demonstrated today. The bow VR, so this is one for upper extremity function. It's a lot of head turning, visual tracking, there's timing, accuracy. The spine rotation, which will be just what it says there, so incorporating spine rotation, weight shifting, upper extremity range of motion while painting pottery. Whack-a-mush is very similar to doing like a whack-a-mole type of activity, so that's also upper extremity range of motion, scanning, and attention. Linda will be taking us through the Bell's test. That is adapted from the pen and paper assessment to quantify attention, visual scanning, and hemispatial awareness or neglect. There's target tracking she's going to take us through, which is actually quite fun. It's the one with the bugs you'll see today. And she'll talk to you and show you a little bit more about how this can be used for mirror therapy. Kristine will be taking you through some examples of how this can be used for speech therapy, specifically the Stroop test, which we might, you said, bump to the end, so depending on time. But that is adapted from the neurocognitive Stroop test, the pen and paper version. There's Reflex VR. This is, again, the balloon popping one where the patient will be asked to, reach. We could ask them to squat, jump, but there's also a lot of cognitive task requirement in there that Kristine's going to be talking to you about. And the Sequence VR, which also has a musical component to it, which is quite fun, but it encourages memorization, sequencing, reduction of impulse behavior, and various motor tasks. Some of the references if you need to see that, but we're going to switch over to our demonstration, and our wonderful, willing Zach Schreck, who is our student from the Mayo Clinic, is going to be helping us with the demonstration today. And I'm just going to work on getting him set in here. So this is the headset. We've pre-fitted it to him to save time, but it's a pretty simple process. Do you have your mic on?
Yep.
Okay. Okay. Feel good there?
Yep.
Okay. We have a variety of hand controllers that come with this. We have the ones that the patient can actually hold and trigger. We also have sensors that can be used if they're unable to hold something. These can also be placed at the ankle as well. Some of the programming you can just switch and use to work on lower extremity activity instead of upper extremity. I'm getting the controllers turned on here, Zach, just a second. Okay. A lot of the programming has the flexibility that we could have the patient seated if that's where they need to start. We can have them standing. We could have them kneeling. We could have them tall kneeling. I could have them, I've done some where they've gotten familiar enough with the program that we've put them on AirX pads to work on balance while we're doing it a little bit. It's up to the clinician how the programs are used. They do have recommendations for what you could use each program for, but it's entirely up to the clinician to make the decision as to what needs to be done. So we watch the patient, see how they respond. Are we getting what we wanted to? And if not, we make adjustments.
The controllers are also being sensed in space, is that right?
Correct. Correct. So let's get you in here. Okay. Okay. All right, Zach, you ready to stand up?
Yes.
Okay, go ahead. Okay. You're good there. Cord's out of your way. I'm moving the chair out from behind you so it's not there anymore.
Okay.
Okay. Okay, just go ahead and look straight ahead for me. Okay, so we have a lot of options here that we're looking at, and I'm just going to take you through some of the program to give you an idea of how we can start at a very easy type of program and move it up to a higher level of challenge. Okay? Let's see. Here we go. I'm going to let you go ahead. Just be sure you're looking straight ahead for me for a moment. Okay? All right, so here we go, Zach. Zach's done this before. So he gets his bow in his left hand, he gets his arrow in his right hand, he loads up, he gets a little white line that'll show him where that's his guide, and he hits the target. Very easy, as we're going to be doing in the middle the whole time. I can make adjustments to the range of motion he has in his arms by setting the bow differently. We can set it so that his bow hand is his right hand and his arrow hand is his left hand. I can put him in different positions for this. I'm going to move you up. So we take you up to the next level, which Zach is too good at this. I'm going to take his guides away. and we're going to have fun. There you go. So here he has to turn a little bit more. Okay. I'm going to bump that up a little bit more. Take your guides away again. So he's got to be looking around. Now I could have him pause if I want to make sure that his arms are getting a break. Okay, arms down. Okay, now you got to come back up to it. So if you think of, repetitions of active range of motion, we're going to work through the range a little bit more so we don't just stay in one area. But he's doing visual scanning, turning his head. We're going to bump you up a little bit more. There we go. These are moving targets. There you go. And then the expert level, which within those you have more control of, where the targets are as far as how high, how far he has to rotate, things like that. But this is just kind of a basic overview of what some of that programming might look like. There you go. Okay, I'm going to take you back out. Okay, so that's the basic of that one. The spine rotation is what we're going into next, Zach. Okay. Okay, go ahead and just start by looking straight ahead. There you go. Okay, if Zach looks around, he can see he's got different paint palettes. He's got a red one to that side. Over to his left side, he's got a blue one. If he looks at his hands, he's got a red and a blue paintbrush. Okay, blue to blue, red to red. So what we're going to get with this one is quite a bit of rotation because I'm going to have him take his blue paintbrush and find his blue palette. He's going to reach and he's going to load up his paintbrush, and then he's going to find the pottery to paint, and then he's got to reach out. Okay? And he gets a nice little jingly sound as a reward, auditory reward. Within this one, we can change how far he rotates by changing the position of the palette. We can change the position of the pottery. So if we do, we can raise those up a little bit. So he's got to reach more overhead. We can offset those off to this one side or the other a little bit. Hoo-hoo, ha-ha, hee-hee, ha-ha, hoo-hoo. Okay. So we can play a little bit there with those, but there's various settings you can get into as far as, you're watching your patient and trying to push them a little bit more. So maybe you have somebody you start centered and you want them to start working out to the sides a little bit more. Really, however you want to imagine this one and what you want to get out of it, you can come up with ideas. One of the things I think we've all learned is no matter how many times you do these programs, based on your patient's reaction to it, you learn something new and go, oh, I didn't think about doing it that way. I'm kind of speeding through these. Got one more I want to demonstrate, and then Linda is going to come and do some demonstration. And whack-a-mush, that's what it was. This one is probably a patient favorite. I have yet to have a patient that didn't like this one, and this speaks more to me than them. I have yet to have a patient that hasn't hit me during this one. So this one can get pretty wild and crazy. We're starting our difficulty at very easy. They're going to have a table in front of them at the very easy level. They have 3 plants they're going to be looking at. All the way up to expert. Right about here we've put in 2. So once we divide into the controllers, so his left controller is going to be red, his right controller is going to be blue. He's only allowed to hit blue flowers, or the blue mushrooms with the right, red with the left. And then when you get up to expert, any of those flowers or any of those mushrooms can show up on either side of the table. So he might be having to reach cross body to get to them, but he still has to match up blue to blue, red to red. And then there's also what we consider traps, which is the flowers. He's not supposed to hit the flowers. He's only supposed to hit the colored mushrooms. So we're going to get in here. Go ahead and just look straight ahead here first. And then we're going to have to do some. He can do this seated. He can do this standing. I'm guessing I'm going to need to raise this table height for you a bit. How that feels good? Okay, how about how far away from how far?
Good.
Back a little bit. That good?
Yep.
Okay. So then he would start. He's looking around. Got to get the right mushroom with the correct hand. Now this can be slowed down. That's the most frequent setting I have to change, is they move very quickly. So I can change how frequently a mushroom appears. I can slow that down. I could speed it up. We can remove the traps if that's just too confusing for them at the time. This becomes a very cognitive task. Which one patient I was using it with, that was the intention, was for it to be a cognitive task. But what it really came in to play was, she was great until we put two hands together. She was affected on the right side, and as soon as we put the left hand in, she just forgot what the right hand was doing and would drop the controller. So that was something we then worked on. That kind of gives you an idea there. Let's take you up to the highest. This is fun. There you go. So now he might have to do a little bit more cross-body reaching. Zach is on the list of people that have hit me during this. I forget how long his arms are. So, but again, that was my fault. That kind of gives you an idea of some of the programming there. I'm going to take you out of that, Zach, sorry. Sure. Okay, and I'm going to turn it over to Linda to do some of her examples.
Okay, I think I'm on. I'm Linda, I'm an occupational therapist, and Lisa's already shown some nice applications for reach and trunk mobility. So I'm going to focus a little bit more on what we can do for visual perceptual skills, especially left neglect or left spatial neglect. So Lisa's going to get him sitting down, and we're only going to need one of those controllers, so I'm going to take this one off. Okay, sorry. All right, so she mentioned the Bell's test, and the Bell's test is a paper pencil task that we use to assess for a visual field deficit. It's just a very simple task where they go through and they circle or cross out all the bells they see on the page. So we have an adaptation for the Bell's test, which uses a much larger visual field. Let me find it here. Okay, I'm just going to start with the settings they already have in there. So Zach's job is going to be to target the bells and highlight them when he sees them. So I'm going to hit start. And Zach, if you could try to find all the bells. So someone with a left field cut might find all of the bells on the right side, but not see any of them on the left side. We can also look at how organized his tracking patterns are. And this is a nice tool to kind of reassess progress down the road. There's a few things I can change with it to make it easier or harder. I can make the bells larger. I can reduce the number of bells that are there. I can reduce the number of distracting items. I can also, let's see if I can find my mouse here. I can also make it more three-dimensional. Just to change the challenge a little bit for him. So typically I would have the patient just tell me when they thought they found all the bells, and then we'd stop there, but I'm going to let Zach keep looking so he can find all of them. There are two more.
You can do it, Zach.
It's much more difficult in 3 dimensions.
Oh, I could change it back if you want me to. Let's see if I can bring that back down to a flat screen. One more.
All right, help me out, everybody.
It's all the way on the left.
All right.
Okay, got him. Okay. So that is the Bell's test. And then there are a lot of games we can use to help retrain someone to pay more attention to the side that they're neglecting. Typically, it's the left neglect. So I'm just going to show one game we might use to train someone to attend more to that side. So, And this does have an auditory component, so Lisa's going to hold the mic up to his ear for that.
So he hears through the headset, but you guys will hear through the microphone.
Okay, so this is a bug zapping program. So and I don't like the fly, so I'm going to pick the bumblebee. And I'm just going to hit start. And Zach's job is going to be, actually, let me center you. Got your head right in the middle?
Yep.
Okay. His job is to find the bumblebees and get them within that target area, the red circle, and then that will zap the bumblebees. I'm going to go ahead and hit start. So we can work on tracking to all sides. I'm sorry? We're not hearing it, are we? Zach, are you hearing it?
Yes.
Okay. So in this mode, it has a little green arrow track to help guide him to find the bumblebees, but I can,
Barely hear it.
Oh, no, I can.
okay,
Yeah, we don't need to hear it.
okay.
But that's coming through his right and left, so it is giving him cues as to.
Okay, so now I took the green arrow away, so he's got to work a little harder to trying to find the bumblebees. If I want to make that a little bit easier, I can change the size of the target, make it a little easier for him to find them, make them really big. If I want to make it harder, I could make the red ring smaller. So now say someone's having a really hard time looking to the left, and I want to make it a little easier for them, I might remove the outside field to just make the field a little bit smaller. So now he doesn't have to turn his head quite so far to find them. But let's say I've got someone who doesn't pay attention to the left side at all, and I really, really want them to focus their attention on that side. So what I could do is remove the right visual field and reduce the targets on the right side, so he's got to spend most of his time attending to the left side. And let him find a couple more bees there. There's one. Okay. Another thing I can do is if I just really want to work on those wide gaze shifts, I can remove the targets in the center of the visual field. So now he's got to just scan side to side, whoops, sorry, to try to find those bees. So we're doing wider gaze shifts. It's a lot more fun than paper pencil tasks, and it allows us to work in a dynamic environment and a wide visual scanning. So, okay, I think that was it for that one, so I'm going to stop. And the other thing I wanted to show today was the mirror therapy, so it'll take me just a moment to set that up. So I'm going to take this, thank you. And I'm going to put the little wrist sensor on. Let me turn it on first. Okay. So mirror therapy is an intervention where you use the reflected image of the uninvolved arm to kind of trick the brain into thinking that you're moving the affected side. And it has applications for use in stroke rehab and pain syndromes like chronic regional pain syndrome. Upside down. Okay. It's typically done with a mirror box where you hide the involved side inside the box and then do a series of exercises with the uninvolved side while you're watching the reflected image in the mirror. So in virtual world, it's a little bit different. Okay, I'm going to make his right hand his motor hand, so his left hand would be the involved side. I'm going to choose a light colored hand for him, and I can also adjust the size of the hand. Okay, do you see your hands? Okay, all right, I'm going to enable the mirror. So right now he is moving his right hand, but it looks like he's moving both hands. And I would have him do different exercises as he's watching his hands move. But I would probably want to actually hide the motor hand. So now he's moving his right hand, but it looks like he's moving his left hand. So we do have another application of the mirror therapy. I'm going to show that really quick as well. Sorry, Zach. They are working on new programs to work, but this is what we have for now. This is, oops, there we go, mirror ball. So this uses the mirror, and in this case, he's going to try to bounce the ball off of his hand. Can you see your hands? Okay. And I have to launch the ball. So let me, I'm going to hide your motor hand, and you're going to bounce the ball. Okay. He's pretty good at it. He's been practicing. Okay. So that's just a couple applications for occupational therapy and in virtual reality. Okay, Kristine?
Maybe that makes too much noise. There you go. I'm Kristine Sankey from Speech Therapy. I'm going to go through a few of these with you. This first one is the Reflux VR. It has a cognitive component to it, but truthfully, this first one that we're going to do really encompasses all three of our disciplines. And I'm actually going to have Zach stand up for this one. When you're ready. Okay, I'm going to take the chair away from behind you. Okay?
Yep.
Okay, look. So you can see on this one, we can do it with one hand. With a patient that has only use of one hand, you can use two. We can add the cognitive component of them using red and blue controllers to use their right and left. And as you'll see, they'll have to find the same red or blue balloons on the screen. I can change the wall, I can make it taller, I can make it wider, and so this is where like PT and OT will come in. In terms of PT, they can have the patient stooping down, they can have them jumping up to reach things, even as they reach their weight shifting. For OT, they're doing a lot some of the visual scanning as well as the upper body reaching. And then for speech, we're working on that cognitive component, so we have direction following and attention to these tasks. Because similar to some of the other ones that they showed, there's those traps where that selective attention, we want them to focus on something and make sure to avoid other things. So in this case, it's avoid the yellow balloon. I'm going to hit start. Are you centered? Let's see. Straight ahead for me. Thanks. All right, so I'm going to move this wall back just a little bit. All right, and you can see here, like I can change the back wall. I can make it more distracting. I can even take it away. So we'll just stick. All right, and so when I hit start, he's going to just be popping the balloons. Can you see your controllers?
Yes.
Oh, you can. Okay. All right, so go ahead. I'm going to let you start. So he's supposed to avoid the yellow and hit the green balloons. And I don't know if you can hear, but he's actually hearing a popping sound in his ears as he pops those. All right, now I'm going to pause it. Like I said, this is a pretty big one. I can make this a lot smaller so he doesn't have so many to look at. And I'm going to change it. You can see up on top the controller mode. I'm going to change it to red and green. So now as he looks at his hands, one is red and one is green. And he's going to be looking for either the red balloon or the blue balloon. And again, some of the stuff that Lisa talked about in hers, down here where you see offset left and right hand, I can change it so the balloons will be on all to one side or one all to the other, so he has to cross midline to find them.
Is this the program that you try to enable jumping?
Well, I can, the PTs would, I wouldn't, but I can make the, up here, see where I can, I paused it for a second, Zach, sorry. I can make the vertical wall really tall, so he has to really reach up there to get, you'd have to almost hop to get to that one. So that's where those parameters you can change depending on what I'm working on, what they're working on, and what the needs of the patient are.
Does that change your safety assessment if you happen to leave the ground? Very much for that.
Yes,
For sure.
yes, they would start, we'd first verify that they can do that in a real world, in an IRL environment, okay, and see what they look like doing that. Probably have a practice in the headset without even looking at targets first. It should be a gradual progression. Can't see their
Right, right. All right, so I'm going to quit that one. I'm going to bring him back the chair. Zach, you can have a seat. Okay. This next one is called sequencing. This is the one that gives us a virtual keyboard. And this one obviously works on sequencing tasks. It also has a memorization component to it. We talked about like some of our patients, for example, with traumatic brain injury that might be impulsive. It can work on reducing some of those behaviors, and then just general hand-eye coordination. So this is going to be a keyboard. I'm going to hit start. That's up pretty high, so I'll have to bring it down to where he can see it. Now this one, again, you can make lots of changes depending on the cognitive needs of your patient. I can pick a different song that has more notes. I can pick a song that has less. Let me try to find. So like this one, for example, only has, 5 notes to it. So depending on how challenging you want that to be or how challenging it would be for your patient, you're going to change that. I'm going to move, do you need me to move it out just a little bit? Is that better?
It's good distance.
Okay, and so Lisa has the mic so you can hear him play. So we're going to start with this first one. I'm going to hit start. It's going to give him the song to follow. Less notes. Now this particular one is giving him a cue and he's following along with it. He is not to hit the note until it comes down to touch the note. So that's where I was talking about like those impulsive behaviors. Some of these have a longer drop, and so the patient would have to wait before they hit it. I'm going to pause it for a minute. And again, I can make the patient only have to do 8 notes all the way up to 40 notes as they play through this. There's variable modes. There's also free play where the patient can literally use their creativity and play anything they want. Actually, just as he was playing, we were saying, he can work on simultaneously moving both hands to make sure he's hitting the notes. And the last mode is this step-by-step mode. This one, it's kind of like that game Simon Says where it's going to prompt you and then you have to remember the sequence and follow along with it. Oh, sorry, I got to pause that for a minute. So he has to remember these notes and try and reproduce them. Okay, and of course, like again, you can make this easier or harder as you go. I am gonna pause it for a minute, Zach. I'm gonna show you this one. You have to actually memorize a whole song too. So that's where that real memory component comes in. Let's pick a different song. All right, it's gonna play the whole song through for him. Well, the whole 9 notes. There you go. Good job. Good job. All right, so that's a little bit harder, a little bit more of a challenge. So that's the sequencing one. Again, it's nice because it allows you to get to play some music. The last one I'll show you really quick because I know we're almost out of time. This is the Stroop one. And again, this is used as an assessment by our neuropsychologists. Did I miss it? Oh, thanks. So this one, again, I can make it smaller or larger depending on its needs. Going to make it a little bit smaller. So in this case, he's going to press the written word. So every time he sees the word red, that's what I want him to press. He's going to ignore any of the other written words and ignore the colors at this point. So again, we're looking at that selective attention. I'm going to look straight ahead. All right. So again, he's looking to press the red text. So anytime he sees the written word red, and I can make these appear faster or slower. I can add some cognitive load by saying, I want you to tell me the color that you see show up no matter what.
Orange. Yellow. Yellow. Green.
Good, so we got that.
Purple. Orange.
Good. Now I can, oh yeah, that's the one you have to do again. Now I can flip it and say, change his attention, and this time he has to pay attention to the color and not the written word. I'm gonna move that wall out just a little bit. Okay, go ahead. So this time he's gonna press anything that's the color green. Again, I might add cognitive load and say, okay, now I want you to read the word for me. Or I might say, I want you to tell me, go ahead and read the word.
Yellow. Blue. Yellow. Yellow. Red. Yellow. Red.
Good job. All right, I'll stop it there. So those are some that show some of the cognitive exercises you could do with patients. I know that wraps it up for all of us, unless there's questions for anyone.
For the module choice, here's Slovia. What's the intent of those programs?
Oh. Start a program.
The sort. Oh, okay. So the crowd, sorry for not being familiar with this, they sort them by what the suggested use for them is. So your crowd VR, I've gone through this one before. I haven't actually done this one with a patient, but this would be somebody who has a hard time being in crowds. So they would be moving around in an environment where you control the number of people that are there. You can start it very low with like 1 or 2 people, and then you can set the time for, a new person walks into frame every 1 second, every 5 seconds, every 10 seconds, and you can set a max for like how many people are going to be there. Are we getting up to 10 people, 20, 100? You can, it can get pretty crowded, and they just walk right into you if you don't move around them. Escalator. Just what it says for people that might have difficulty being in that type of environment. Same with the elevator. The elevator is a little bit trippy, I'll tell you that. I've been in that one, so you start on the ground floor and it gives you the sensation of moving up in a glass elevator. And then the relaxation VR would be kind of the opposite of these. So after having been in these and that kind of more intense environment that you were working on, this would be kind of to bring you back down, where you're just kind of in a forest and there's kind of the sounds of the birds and the wind and the leaves and kind of more of a meditation type environment. I will say I have not used that one yet.
Did you find out anything more about motion sickness and if they're using this for treating motion sickness?
Yeah, we have modules that will work on motion sickness. So we have the car simulator, which would be an exposure task where you're trying to desensitize to car sickness. You can be the driver. You can be in the passenger front seat, rear seat. There's a module on there for reading. So if reading's something you have a hard time doing in the car, there's also there's the one on the boat where you're, and that one is done in the platform, in the Motion VR platform, where you can control, are you on a rowboat or are you on a cruise ship? You can control the height of the waves. You can control is there rain? So you have that other visual stimulus of, clear view versus a little bit of rain versus angular, that kind of visual disturbance. All right, well, if anybody else has any questions, I'm sure there's some sort of contact information here, or we're down in the medical arts, rehab and wellness. Please, if there's anything we can do for you, let us know, and we'd be happy to talk.
Thank you.